Hello, everybody. This is Dr. Randy Bach. Today's August 9, 2021, and we're here for another episode of Dodging Cancer, which is a series that aims to separate some of the myths from the truth of cancer and give people and patients and families of those with cancer a perspective on how best to proceed with what is almost invariably a frightening diagnosis and a harrowing time. A veteran of these wars, and probably with the scars to prove it, is Thomas Masty, who's a good friend of mine and a skilled communicator. And so, like Ernest Hemingway, I guess in World War, no, it was the Spanish Civil War. um, if you have the right person in the right place with a perspective and a skill in understanding and narrating the human experience, then you'll come out with more perspective and understanding about that. So, once again, this is part two of my interviewing Tom. Tom has been kind enough to quiz me about certain aspects of cancer. We have some other episodes up, which I'm happy to reference. But these last two episodes, we have done a role reversal in a sense, and I'm interviewing Tom because he has far more experience um, from a patient's perspective of cancer. So, um, with that as partial intro, I mean, we've covered some topics. I don't want to, go over ground already trod. So, please caution me if I'm doing something that's, somewhat repetitive, and I apologize in advance to the audience and to you. But one thing that we recognized from watching last Friday's episode is that on the question about what it's like to get the diagnosis of cancer, you were talking about the sarcoma. And, again, for better, for worse, you have had different cancers, and you've had an esophageal cancer as well. Maybe you could just, kind of fill in some of the other experiences you had with that, how they were different, different diagnosis, different age, different time, different so forth. So I'll keep quiet and give you the floor.
Thank you. There's 2 points I think I'd really like to make related to the last show. The first one is that I've had cancer now, serious cancer, 4 times.
Hmm.
Twice it was a stage 4, meaning it metastasized from the original site to somewhere else. Uh, and so I'm still here. Uh, it isn't a death sentence necessarily when you hear stage 4 cancer. And most of us, including myself, tend to, you hear it and your heart slumps and you tend to think, oh, this is the end of the line. But it doesn't necessarily mean that it is. My first cancer was in 2007. And so that kind of gives you a perspective. The second issue is that in it was when the cancer of the esophagus metastasized to the lung that the doctor said you have between uh, a month and 8 months left to live, depending whether or not you have the surgery. And that really hit me hard. And as he's talking, I was trying to listen, but my mind was racing toward, okay, what do I have to get in order? Because I'm going to be checking out soon. And I'm glad I had my wife there because she was able to hear. I mean, her mind did the same thing, but between the two of us, we were able to gather more information than had I just been there alone. The one thing I wish I had done is made an appointment to go back and see his nurse after the fact, just to verify what we thought we heard,
Hmm.
and so forth.
So
But
how did it come about to get an esophageal cancer diagnosis? I mean, what were the signs? I mean, what type of things you've had some experience now? I think a lot of people worry, if there's some cancer brewing behind the scenes. I've had patients come in with any, almost every symptom in the book you can name, and a lot of times in the back of their mind, they're like, I just want to make sure this isn't cancer. Um, Now, you haven't had every symptom, you haven't had every cancer, but were there moments in time when you were thinking certain symptoms might be cancer and you were wrong? Pre these 2 episodes or 4 episodes, however you want to count them, or conversely, were you taken by surprise, or did you have a suspicion? And how did that all work out? I mean, as your symptoms grouped together for this, and we'll stick on the esophageal episode
Sure.
and episodes with recurrence.
Well, the thing is that with the esophageal, I thought that I had cardiac issues,
Hmm.
and the tremendous pain that I was having was acid reflux. And when they scoped it, they found Barrett's and a couple spots that they thought looked cancerous, so they took the biopsies, which came back as a carcinoma. So that was I. I had had acid reflux for years. I had been taking doses of uh, Zantac, Tagamet,
Hmm.
omeprazole, whatever, and various antacids for years. And none of us in my family and friends knew that acid reflux could turn into cancer.
We've spoken about that a little bit, and I don't want to worry. Heartburn is nearly a universal symptom at some point in people's lives. I- if you hit middle age, um, it's almost impossible to avoid a few episodes of heartburn. I think that's pretty standard business, and it's an interesting phenomenon by itself because the stomach makes pretty harsh acid pH 1, um, which is, I think, maybe 5,000 times more acidic or 10,000 times more acidic than lemon juice, for instance, which is pretty tart. Um, and it's pretty powerful stuff, and so your stomach's actually okay with that. Um, but I always compare the GI tract a little bit like to a car wash. There's a different, if you ever sit through the car wash with your car, there's different phases, the brushes, the this, that, and your gut is somewhat like that. You chew the food, and then you swallow it, and so the esophagus is just kind of the holding to get, push it down there, and once it gets through the doorway of the stomach, then the acid wash comes along, and that's really super duper. But that little doorway gets loosened as kind of all our flesh loosens up over time, and so some of it goes back the wrong way, and that kind of constant irritation can um, breed the heartburn first of all, and then the more frequent irritation can lead to cellular dysplasia, because the cells are keep multiplying and creating more of themselves, and the more time you roll the dice, the more time, more likely you are to roll snake eyes, which can be a dysplasia and then possibly a cancer. So that's kind of how, um, you know, heartburn leads to Barrett's, leads to esophageal cancer. But, the pathways by no means that frequent to reach the completion to esophageal cancer. But certainly, it's the other way around. Most people with esophageal cancer have had, certain amount of heartburn. Very few people with heartburn will go the other way. So it's kind of a filter funnel effect. But it is a reasonable warning sign for people who've had severe multiple episodes. So I don't
I
want to
will.
get
I'll also add that famotidine has been my best friend in that it knocks out the acid very quickly when you're having a bout of that.
right.
And so, talk to your doctor about whether that's
Absolutely.
appropriate for you.
Yeah, and I'm kind of old fashioned as far as this goes. I'm both, I've treated a lot of heartburn. I've got severe heartburn myself. I almost literally thought I had a heart attack once, and once I thought I had, like, such back pain, like as if somebody was stabbing me. But both times it turned out to be heartburn, very severe. But I kind of like I like the old style. I don't think they make it anymore, but Maalox, also Mylanta, that kind of stuff. The liquids are really quick, and they get right to the point because they are literally antacid. So it's kind of like a fire extinguisher effect. So just, this is a little off topic, but that's my medical tip of the day, is to keep some liquid antacid around, because they really works. And you can do the other pills and so forth for, more long-term prevention.
But especially if you have a hiatal hernia, that it'll complicate things and give you
Right.
more acid reflux too.
Right. So let's get back to you. And it must have been stunning, not in a beautiful way, but stunning as if you're stunned to think, oh, months.
Deer in the headlights.
Right. And so what's I get it that you can't really digest and absorb things right then. My other little medical tip is, people have smartphones these days, and I think it's very helpful to do like with permission for all parties, a voice recording of what the salient facts are, so that you can play it back for your relatives and hear it again, so forth. I encourage that in physicians' offices, um, presuming everybody's agreeing and understands being recorded and you're not going to rebroadcast, etc. But a lot of times having that information, being able to hear it again or play it for somebody else, is very helpful. But so you get that first phase. We've talked separately about the kind of the Kubler-Ross. That's, I guess, she's a nurse who famously came up with kind of the 5 cycles of grief. And we can go into those particularly. I don't really want to hear them right this second, because I'd rather talk on a personal basis. What happens, and how do you mobilize yourself, and what do you do when you get uh, what seems to be a kind of a death sentence of sorts? Um, what's that like, and what's that about, and do you have recommendations for other people?
It's horrifying. It's mind numbing. It is a it's a difficult thing to describe, because it's almost like watching a movie where everything goes in slow motion,
Hmm.
and you're hearing the doctor and your mind is racing at a million miles an hour, and you're trying to absorb from multiple sources of information and come to grips with it. And at some point you kind of sigh and go, it is what it is. I'm just going to have to ride with it.
Hmm.
And I think that how quick you come to that conclusion that you're going to have to ride with it and make the best of whatever the situation is, the better.
Hmm.
It's easy to stay angry, or why did this happen to me, or where's God, or those kinds of complex questions. But that's not going to get you anywhere in terms of uh, being able to make the right steps, listen to the doctors, and do the follow-up appointments, and hopefully, as you would say, Dr. Bach, dodge cancer.
Well, I mean, to be fair, you came up with that phrase, and so again, I think you have a good way with words and concepts. Um, so let's just kind of in very literal sense, um, plot out, what would be your day planner for the next 2 or 3 weeks when you hear something like that. And I'm going to have to step away for 1 second, so I'm going to give you the floor,
Okay.
and I'm going to be back in less than a minute.
Okay. Well, if one was given that, when one is given that diagnosis, one needs first to, I think, take some time and center oneself, and talk to their spouse, talk to their family, uh, pray. I think that prayer plays a large role. Uh, Close friends, having them pray for you makes a difference. At that point, you need to sit down and make a chart and say, okay, what comes next? The doctors are really good at giving a referral to the next physician you need to see, whether it's a surgeon or an oncologist or whatever. But you need to sometimes take the bull by the horns. If you call that oncologist and say, you know, I really need to get in there, and my appointment's not for 3 weeks, but I'd like to be on the list of people who cancel. I'll come down right away, and if you have a cancellation, can you call me? The secretary, the administrative assistants, and people like that, they'll usually try and work you in, and I think that's an important aspect to do.
Uh, Well, first of all, I got to hear all of that. Um, and I think those are really excellent points. I wanted to go over kind of some other, maybe, kind of nitty gritty things. I mean,
Sure.
you've had experiences with radiation, with chemotherapy, um, with surgery. Um, so what would be the Tom Masty guidebook? We were
Ask
talking
for the
about
good drugs.
we were talking about the way this is a little bit like travel, and you liked my comment, and I appreciate that. And I said there's a little bit like traveling to Europe, but you don't get to make the itinerary. You're on somebody else's tour, and it may not be all all the places you want to go. And of course, in a sense, the tour can be hijacked, I guess. Worst case scenario. Um, and you wind up in a destination you have no interest in going. Um, so without making this into a gruesome movie, what are the kind of things that you have to be on your well, okay, so what's the playbook, what's the guidebook, what would be your tour book for this situation, so far as one can have one?
Well, I think that I've always been fascinated by science. So when I was told that I needed proton beam radiation, for example, I went in and there are all these amazingly big machines in this whole room, and this kind of doctor who's like somebody out of a movie, Dr. Leach, who's brilliant, who built the Proton Beam Center at Mass General in Boston, and he's an Austrian, and he has this very funny accent, so it's kind of really like a film. And he comes in, and he says, "We are going to make a mask for you, and bolt your face to the table." And you're like, "You're going to do what?" And if you go along like, okay, teach me along the way, and he would hold up like parts of the machine and say, oh, this is an interesting part, this is what it does. And you know, they bolt your face to the table instead of the patient moving like you would in a CAT scan where they move the patient back and forth. The entire room moves, so the
Hmm.
soft tissue doesn't move in the body. And so you're in this big cylinder that's maybe 15 feet across, and all the equipment in it is turning slowly with big gears as they focus the proton beam machine onto you. And it's just like something out of the movies.
Hmm.
And if you go in with a little sense of awe, and you ask for information, you'll get it's a little bit more enjoyable. On the
Hmm.
surgery, I always enjoy the anesthesiologist, and I ask what flavors they're giving that day, and I try to see whether I'm going to feel it or not. Now, propofol, I just knocks me out, but some of
Hmm.
the other stuff, you get kind of a real pushy feeling as it goes, and it's a matter of enjoying the experience, even though you're
Yeah,
really scared.
yeah, it's like traveling Syria or something. um,
It's like Spirit Airlines.
yeah, even if you pay extra, I think your seat still does not go back. Um, I've been on them, and it's interesting. So, yeah, I have a friend who has traveled literally every country on earth, and for most of those countries, most all of the individual provinces or states of those countries. And he still has two glaring absences: North Korea and Iraq. He has not traveled to. Um, so, speaking of like travelogue and itinerary, and getting your tour hijacked. So, maybe a little bit, some of this is like, traveling, war torn Iraq or something like that, where you don't want to be, but it still might be fascinating. So that's an interesting perspective. I think it's highly mature. It's kind of a place we'd all hope that we could achieve, and so forth. It's not always possible because I think people tend to worry, and I think it's
Oh, Dr. Bach, can I add in that if you tell the nurse, I'm scared, if you're honest with the nurse, they'll take your hand and walk you through it. They're the most kind, loving, giving people in the world. And I have never encountered a nurse that didn't go out of their way to make me feel more relaxed and comfortable,
Hmm.
whether it's going to the doctor and saying, can we get a magic pill to, dope them up a little bit? Or I also remember coming to in the hospital after the surgery and with the CSF leak, and the nurse was holding my hand. I mean, there's a program at the local hospital where I lived in Florida, and it's called No One Dies Alone.
Hmm.
And they have people who volunteer and come and sit with those who don't have someone else.
That's
There's
amazing.
a lot of compassion in medicine that people don't tap into because they don't know to ask for it, and they're afraid to say they're afraid.
Hmm. So I've got a quick question, just to interject about medication. Um, do you do you I don't know. I mean, I assume you've been treated with narcotics after a surgery and so forth. What is the level of pain after one of these procedures, whether it's radiation or surgery, and what's the need for narcotics? And how do you acclimate? Do you acclimate? Do you find any kind of addiction going on, or not so much addiction, but that the drug, effects wear off the more you get used to them?
Yeah,
Um,
dependency.
and was that an issue at all for you or people you might have known? And I guess a secondary question, maybe I'll pop this in, is speaking of people you might have known, did you meet people along the way, other patients, and I don't know, in treatment or whatever, and is there a kind of a camaraderie um, of it being in the trenches? So that take either one of those questions first.
Well, let me take the second first. Is yes, there is camaraderie. Is that I have seen more acts of kindness from one patient to another in the waiting room. Uh, I have seen patients who have been treated and cured come in just on their own to cheer up other people in the waiting room. I was in Boston, and this guy, it's a little strange, but he came in as Blackbeard the pirate, and he's doing this whole routine, and we're all laughing, and he just did it to perk everybody up because he knows how tough it is to go through chemotherapy.
Mhm.
And the nurses were all laughing, and he had everybody just holding their sides. The guy was so funny,
Hmm.
but it was just an act of love on his part. And so yes, there's a camaraderie, but as to the medication, it's a the narcotics can be useful in some circumstances, but after the lung surgery, they gave me, I think I had a couple Percocets when I was in the hospital, and that was it. It wasn't a really painful experience.
Hmm.
However, when I had the CSF leak, uh, just lifting my head off the table was excruciating. And I don't know what they gave me for that, but there was one injectable that was useful, but everything else didn't seem to do anything.
Hmm.
The It depends on the circumstance. I never got a dependency to it.
Hmm.
Uh, Although my mother was an oncological RN, and growing up, I would help with the families of various cancer patients. Those who have bone cancer are in a completely different category of pain,
Hmm.
and that's why hospice is so important. Is that they have access to prescribe the heavy duty narcotics that the regular MD is not going to want to prescribe,
Hmm.
for especially due to all the abuse of narcotics that's taken place in the past
Right.
20 years.
Yeah. So I just want to put kind of maybe a little bit of a public service announcement. Um, I had probably nearly a decade of treating uh, uh, addict issues, not my own, but I saw uh, probably 1,500 different narcotic addicts over about a 10-year time, helping them gradually detox to sobriety. So that's a whole nother topic of interest. Um, but I don't think there's frankly that much overlap between incidental narcotic usage through genuine pain situations and kind of like going off into a tailspin of personal destruction and pursuing narcotics illicitly and whatnot. I often heard that people had a back pain or something like that and they started on pills and whatnot, but the more you dug, a lot of times there were other emotional issues that had predated that as well. This, I don't think is a standard message out there, but um, I think that people who are in pain from narcotic issues, excuse me, from cancer issues, um, should not really be thinking about longer term addiction. I don't think they should overdo it. I don't think they should take the pills if there's no pain, and I think they should be cautious. But that tends to be what people are anyway. On a personal basis, I've taken narcotics maybe only once or twice in my life. I had a kind of a severe injury at one point, and I was given Percocet or something of that sort, and it was like awesome. I had kind of like great dreams, fluffy floating tigers and songs and whatnot. And I woke up and I was like, wow, that was really great. I don't want to do another one because, I could, you could like hang out there. So I think there's kind of a natural, what I'll call a frugality or parsimony or care that people have about their good experiences. We all like, a party, but we don't like to party all the time. But I don't think that's necessarily a real worry for the cancer patient. And if you're having, I wouldn't take the stuff just to take the stuff. Um, but I think you have to not want to mask your kind of sensorium, your awareness of the world, and you need to be calculating. You need to make appointments. You need to be on your toes about things. You don't want to be ignoring the world around you and the people who want to care for you, so forth. So
Would you agree with me that if you're crushing it up and smoking it, you probably have a problem?
It's funny you say that because people are smoking a lot. The former president, Mr. Obama, had a huge birthday bash, 60th birthday on Martha's Vineyard just a day or two ago. And I guess for the what do they call that little grab bag at the end, party bag, the favors, he apparently put real live marijuana in for everybody. So there is kind of a little overlap, not so much crushing and smoking the opiates, but there is, marijuana or cannabis is becoming a popular thing for, and then I think there's a role in cancer for, treating diminished appetite and kind of, to keep your weight up and whatnot, because it does give you the munchies. I think there's, probably a little bit of the pendulum swinging so that, CBD and cannabis is, treating everything. You can have a hangnail. It's like, oh, cannabis does this, anxiety does that. And so I think that people are, a little bit overeager with that. So maybe not so much crushing and smoking the OxyContin or whatever. Yes, I think that's an issue, joking aside. And obviously selling it or pursuing multiple doctors to get it, all those things are warning signs of narcotic issues. But I think there has to be some care that if you're going to be, offered marijuana, which pretty much everybody will tell you these days, you have to, again, be careful about, how you want your life experience to be.
It is a drug.
It is a drug, and on the downside, without being morbid, I mean, we like to presume that everyone with a bad diagnosis is going to survive it, but not everyone with a bad diagnosis is going to survive it. And it's not just about your own feelings; it's about kind of, in a sense, the responsibility you have to others, even with a cancer diagnosis, to be, that uncle, to be that grandfather, to be that husband, uh, and so forth, to be the spouse and friend and partner and community leader or participant that you were. And it's not, obviously your expectations are going to diminish when you're ill, but it's a little bit of what I call the dynamic tension of life. That is, there's some tension. You're doing things that kind of keeps us alert and awake and participatory, and I think it actually helps the fight against some of the things that go along with cancer. And narcotics are depressants, and marijuana is a mild depressant as well, and it can make you lethargic and kind of take away some of your fight, perhaps. And so maybe there's a wonderful world of the lotus eaters, as one of the romantic poets announced. I think it was Coleridge or something. But I think there's a place for all that, and you don't want to deny your pain and so forth. But I think you also want to, insofar as you can, be the person you are.
Can I toss out that that mental health is something that one needs to be very aware of during the cancer process, and that seeking counseling, seeking antidepressants, things like that, definitely has a place for patients who are going through this. I've known people who were incredibly depressed because they had young children and they'd been found with a brain tumor and so forth. They had high anxiety. There were medications that they were able to be given and things like this, and that there shouldn't be a stigma against pursuing that kind of treatment.
Mm-hmm. All right, so I'm going to go to one of my scripted questions here.
Okay.
You again have had some experience. I was wondering whether you might want to walk us through the chemo experience. You mentioned FOLFOX. I could fill in some of the blanks in what that stands for, but you were talking about the anti-nausea medication, and maybe some of the problems, anticipating chemo, having chemo, after chemo, and I think you also mentioned some neuropathy issues and so forth.
Yeah.
Maybe you can kind of give us the landscape, the tour guide view.
It started with the doctor prescribing FOLFOX, which is oxaliplatin, and there's another drug involved in it.
Right. There's leucovorin. There's fluorouracil. But I can I interject slightly the nature of chemotherapy? Give me just a minute, perhaps.
Sure.
I mean, chemotherapy actually came out from nitrogen mustard gas. I think it was World War I. They had found, I don't know if it was coincidental or how precisely, but the Dana-Farber was a real person, Dr. Farber. And a lot of his initial research with chemotherapy was using poisonous gases, because he found that it reduced your white blood cell count. It killed a lot of the rapidly multiplying white blood cells. And he thought, oh, well, the lymphomas and leukemias are rapidly dividing white blood cells. So a lot of the original chemotherapies are literally poisons. And the thing is, I like to point out, if you take an antibiotic, to kill your strep throat, your streptococcus bacteria, or tuberculosis or whatever bacterium, you are taking a poison, but it's a poison for the bacteria. It's not a poison for you. But bacteria, their genome is so different from ours. There's not that much overlap that you can kind of, take, like, imagine a gun. You can shoot the bacteria, not harm the person. But your cancer cells are you. They have the same DNA as you do. They're, mutated a little bit, and they've stopped listening to anybody else, any other cells telling them not to grow and overgrow. So they're bullies, and they're gang leaders or whatever, but they're still human cells in the same sense. And so the profile of kind of poison that you can get that cancer cell, which is you, and not get the other cells, which are you, in many other ways, is very difficult. So they've been shooting at the fact that the cancer cells replicate. So the nitrogen mustard gas, and then a lot of the chemotherapy, is going after cells that replicate more. And this is a lot of the reason you lose your hair. You might have skin issues. You have the nausea and vomiting in your gut, because those are cells we have ordinarily that are replicating rapidly. And so in the course of your lifetime, I forget the number, but I think your skin cells, replicate in the tens of thousands of number per lifetime. So they're doing pretty rapidly, every week or two. they turn over completely. And the gut cells are not that dissimilar. And your blood cells are doing it all the time. So a lot of the problems with anemia or losing your white blood cells, losing skin, hair, and getting bowel symptoms are of that order. So anyway, that's just my quick preface. And I'll add one thing, which is the chemotherapy has evolved somewhat. So it's getting a little bit more refined. And then the other layers of immunotherapy and whatnot are going to, not going against replicating cells. And they might have a slightly different, but probably fewer side effects because they're going specifically, targeting those cancer cells in a more refined way. So I apologize for the speechifying. But
Well, it makes sense. It's appreciated.
right. So in that context, let me just go back to the question. Maybe you can walk us through the chemo experience,
Sure.
kind of the anti-nausea medication, any issues you might have had, before, during, and after.
Well, the first thing they did was they put in a power port, which is a little device that goes under the skin and in the chest that allows them to do it basically IVs in the same place without finding veins and struggling. And you can probably define the power port much better than I can.
No, that's reasonable. I would show a picture of it, but we can save that for the comments section.
So
I,
they put in a power port, which is done with a local anesthetic, and a couple days later they start your chemotherapy. You show up, they go through and they access the port, which is done in a secure clean room where they take the port and they put a little device with a needle in it into it and get you up like an IV. And you go into another room and sit in a recliner, and they hang bags of various saline and such for you. They start your drip, and then they add in whatever it is that the doctor has prescribed. But usually before that comes in, they give you a large syringe that's probably about 8 inches long and 1.5 inches wide of anti-nausea medication. And that kind of goes in first, and then they give it. Takes about 2 hours for the bags to empty out, and you're at which point they have in my case, they sent me home with a machine that automatically dripped chemo into me for the next 24 hours. And at the end of it, I would take and box up the machine, and they taught my wife how to remove the needle from the power port with a little special class, and how to box it up in a special box and send it back to Mass General. And you'd go down, then they'd have a fresh one for you ready to go. And so it worked very well. There was one night that the batteries went off on the thing and it was beeping, and I'm calling the hotline and trying to figure out how to make the thing stop beeping. But I did very well with it for the most part. I did have a reaction, which was, we think, to the anti-nausea meds. And it was spastic tremors of the hands and arms and legs. And it took a long time for that to go away. It kept getting worse and worse. And it's also exacerbated by stress. And it seems worse at night when you try and relax. I still have it to some extent. The other side effect I had was you touch anything cold, it feels like you're touching electricity.
Oh my goodness.
And you touch a cold glass and you pull your hand away because you feel it's a shock. And a lot of people have that hypersensitivity. They tell you don't drink a glass of ice water because you'll feel that in your throat.
Oh my goodness. Yeah.
So that's you have to kind of be a little careful. The other area of with Folfox is neuropathy, and neuropathy is where usually the myelin sheath of the nerve and it's usually in the feet or hands, begins to break up, and it feels like needle picks, or feels like a burning sensation in your toes, and you feel like somebody shoved an extra uh, sock into your shoes. You're like your toes are pushing against something.
Hmm.
And unfortunately, that doesn't go away. But I'm alive. And
Hmm.
so you have to kind of balance the two. Is, what would you rather have? Would you rather have neuropathy and still be alive, or have the cancer having killed you off?
Yeah.
And these things are not easy, but they're trade-offs that with your doctor, I think are what.
So when did you have symptoms and problems with or during the chemotherapy itself?
Yes, the very first episode that I had, the anti-nausea meds, my wife noticed some of the shaking of the hands.
Did you have any of the kind of bowel or hair issues that people speak of? And what if you did? How long do they last? How severe? How on a scale of 0 to 10 is horrible. Where do they fall in?
I had some of the bowel issues, and that was disturbing. But I think I ended up stopping at the sixth Folfox dose because the spastic arms and feet were too much to handle.
Hmm.
Uh, some people get through it. When I had radiation to the back of the neck, they said I might lose my hair, so I was preemptive. I went ahead and shaved my head before I
Hmm.
went to Mass General, and I thought I'm not going to watch my hair fall out and look like some bum. I'm going to go in and I'll get some good head wax and do this thing on my terms. And I think that's kind of one of the important lessons is you want to do this stuff on your terms.
Hmm. Yeah.
Anything you've got to find places that you can control. I met Madam Ching, who wrote Life and Death in Shanghai many years ago. She
Hmm.
was a victim of the Chinese Cultural Revolution, and she was imprisoned for 18 years by the communist Chinese. And I said, "How did you get through it?" And she said, "Back then we had pants that zipped up on the side. And every time I went to the bathroom, I made sure that I was the one who zipped up my own pants because it was the one thing I could control that told me I was still in power and I still was a human being and I still had my dignity." And I think that we need to all look for those little things that tell us that we're still human, that we still have dignity, and that we still have some things we can control, even though there's others we have to relinquish.
So that's deep and thoughtful. Thank you. I speaking of control, um, I'm just curious. Uh, I've spoken with a number of different people with you know stories from their cancer experiences, and obviously they're at least so far survivors. Um, Not all of them wanted to relinquish control of their jobs, of their present life, and in fact, one um, professional woman, she works for a major company and she had a very take charge kind of role. She, in a sense, avoided her cancer, um, completely, or at least for a while, until she couldn't. She didn't want to discuss her diagnosis with anybody. Um, and I know of other people who didn't want to discuss it publicly for fear of losing kind of status or opening up the door to your successor. Um, the king is dead, long live the new king,
Yeah.
kind of thing. And even if you're not, you know, quite gone, there's, in a sense, a corporate or a betting expectation that there's a chance, and I think people react differently. Given that you've mentioned the usefulness and the kind of the completion that other people will have for us in helping us go through this and providing information and so forth, and I think you're a great communicator, and it would be hard to imagine you doing this absent that. What are your thoughts on that topic? What are your recommendations for people? How do they make that balance? And what are the pitfalls on either side?
Well, I have a dear friend who is battling cancer right now, who's an attorney, and he is very careful not to say anything about it because he is concerned that people who trust him to make sure their affairs are handled through to completion would run the other way because of his health issue.
Mhm.
And he thinks that his health issue is something that's under control. And they have to explain that he's, going to be here in 3 years or 6 months or whatever the case of the requires is convolutes the issue. So he's chosen a completely different path. But those who are closest to him, he's told us, and we pray for him and with him. I think that there's a certain element of wanting to do things your way. When I was first diagnosed with the sarcoma, I went in and saw my boss and said I need to go back home for surgery because I have cancer in the neck. And he said, well, our projects are important at this company. I assume you're going to finish all the projects before you go. You can imagine what I told him.
It's tricky.
But there's a lot of people who will put their projects first ahead of your health. And you have to decide what's important to you. And cancer is life-changing. It is. You will come out with a different set of values. You'll come out with an appreciation of those people around you who stayed. And there will be friends who go the other way just because it's uncomfortable and they don't know what to say. But were they really friends? I don't
Mhm.
know.
Have you ever been on the other side of that equation?
Yeah, I have. I have. And they say that empathy, I was a teacher, among other things, in my life. And the psychologists in a recent report say that if empathy is not taught in the first 2 years of a child's life, he grows up to be a narcissistic sociopath. And I think that having compassion for others is something that we're called upon to do by our Creator.
Mhm. Yeah.
There isn't a person in the medical, everybody likes to say, well, doctors make a lot of money and so forth. The Bible tells us that we're to heal the sick and feed the hungry and clothe the naked. It doesn't tell us we can't make a living at it.
So I have a bad joke. I've thought about this joke at a couple other junctures earlier in talking with you, and I'm just going to stick it in here. People can skip over this, take 30 seconds. But guy goes to the doctor, and doctor gives him 3 months to live, um, and at the end of 3 months, he hasn't paid his bill, his doctor bill. So the doctor gives him another 3 months. And it's nonsensical, but it is one of those things. Yeah, I mean, the doctor wants to get paid, but it is a, I mean, people will show you compassion because that's what they are, but it's always and also going to be in the context of what they do. We had a wonderful experience with an Uber driver, and just the other day, and he's from Somalia, and he went through tough times. I think there are almost perennial tough times in Somalia, and we had a delightful time, but I wouldn't have had that conversation if I had not been paying him, to do something. And I don't think he just would have stopped in the middle of the street and told me the stories and been as receptive to hear. It's so a lot of our interactions, sometimes our best interactions, are in the context of commerce, because I think people can be relaxed. Kind of when I don't have this happen to me, but when somebody's the commercials, somebody's Madge is doing the woman's nails and they're having chit chat and whatnot, um, and we have our other selves. We don't ignore those, and we don't drop those. Some of my best discussions were kind of off topic. When patients are in the room, we've kind of dealt with the cold sore or the pneumonia, whatever. I mean, and we were talking about something else. So that's kind of a funny thing. But yes, people do like to get paid. um, so I think we've kind of traveled a fair amount here. um, I had one, I touched earlier on the Kubler-Ross cycle, which, just to kind of go over, it's the 5 stages of grief. It's denial, anger, bargaining, depression, and acceptance. And I'm wondering whether that, and supposedly it's one of those, that's 1, 2, 3, 4, 5 in order. I'm wondering whether that happens, whether you think that's fair. How long does it take? And I don't know, is it all a good thing, or is it just kind of what's there and what happens?
I think it happens. I think that some people get stuck on one level. Years ago, I was talking with a nun who was absolutely one of the most spiritual women people that I've ever met. And I said, your life is like this. It's just very stable and straight across. I said, mine is like this. I said, how do you maintain such a calm demeanor? And she said, because I have been practicing all my life.
Hmm.
And I think that when people go through these things, uh, when you're 20 and you get hit with a fatal diagnosis, you don't have the tools or experience to be able to just take a deep breath and say, okay, we're going to deal with it and go forward. When you're in your 60s, it's much easier.
Mm-hmm. So I kind of questioned out a little bit. I'm very much in your debt. Is there anything we missed on this episode?
Uh, I guess we'll have to watch it and find out.
Yeah, no, I don't mean, when I say questioned out, I mean on my end. I could listen to you all day, and so I'm just,
We
you know,
got through your list of questions,
yeah,
and
and I don't have any. There is one of our watchers. Um, the
oh,
prayers, the prayers of so many are with you, Thomas, for a speedy and complete recovery. Your good spirit and humor are an inspiration, and the thanks of many are with you, Doc Randy, for generously sharing your vast medical knowledge.
well,
Um,
thank you. I'd like to mention that this coming Friday, I start my high intensity radiation as opposed to the regular radiation, which is really cool because instead of shooting a straight beam through, which causes the burns, they now have a device that shoots it from a 360-degree circle into your tumor. And so you don't get burned and you don't have all the side effects.
yeah, it's
And
incredible.
plus, I only need like 5 treatments of it as opposed to a whole summer of other kinds of radiation.
Hmm.
And so I'm excited to have it done. I'm excited to learn about it. I'm not really thrilled that I have to do it,
Hmm.
but your prayers would be appreciated. The prayers of the viewers would be appreciated as well.
Well, thank you. Um, I'm just going to leave maybe with one small experience that I've had recently. My One of my college roommates, my first and second year college roommate, he's a radiation oncologist, and he's top notch and a very smart guy and good mathematically and all that stuff. Um, he said, even in the context of his work, um, a year, 2 years, whatever, have brought revolutions, and that things get better almost exponentially. And it's a little bit like maybe playing Pong. That first generation computer game in the 70s, late 70s, and kind of the interactive, immersive games that kids play now, and augmented or virtual reality and all that kind of stuff. The same holds true with a lot of the radiation. uh, I got to look at some of the math, and when I say math, is very you know intense computational algorithms in order to figure out in order for them to figure out how to get the right radiation, right dose. It's a three-dimensional problem. There's all different layers of tissue, and so they do a lot of probing studies and radiography and so forth before they're ever going to dose you. There's a kind of a vast amount of information, a little bit like a military plan, of how to get the enemy, and how to get it precisely, and not and avoid as much friendly fire as possible. So again, this differentiation between human and human, the cancer's human and it's your cells, but there's cells that have stopped listening. So it's a little bit like a hostage situation or a criminal situation. Patty Hearst got kidnapped, and you want to maybe save her and get the kidnappers, that kind of thing. um, and those situations are difficult, but they've been made easier by a lot of the incredible um, uh, again, computational power and the brave people that are putting them through. So we give a shout out of thanks. I on a slightly I don't want to get too deep into social policy, but the United States, we are fortunate in a sense to be here, because even though we pay a little bit more for our medical care, most all the innovation, again, getting back to the topic of people will do better for you when they're getting paid. We tend to be the source of all the innovation in therapy, not just for cancer, and not just pills and so forth, but radiation and whatnot, because there's a kind of a more direct payment mechanism. And a lot of the world will benefit, but they tend to benefit in phase or slightly out of phase, maybe 5 or 10, 15 years later. And so we, no pun intended, again, tend to be on the cutting edge of a lot of these, radiologic knives, surgical techniques and whatnot. And people are very innovative, and we're, always in the debt of people who have kind of sourced and resourced their imaginations and put them to heavy use at the benefit of others. And again, across society, we see some of the instincts that you mentioned of caring, and all the various cancer charities that are out there. And again, maybe this is again topic for another conversation, but there's been no specific cure for cancer, but a lot of the the life expectancy has essentially doubled in my lifespan, in my active professional lifespan, for cancer recipients, the amount of time they have, and cancers are treated much better. So I'm hoping and praying for the same exact thing for you, Tom.
Thank you.
And if you have any other things,
In a future episode, let's talk about some of the resources that are available, some of the places that people can go to give them leads of organizations that will help them.
Okay. Well, I will do that and make a note of that. And I appreciate your time once again so much. Thank
you.
you. Have a good day.